And I will start with the first one, which is Dr. Erin Ross. She holds a master's degree in speech and language pathology, and she's also a NIDCAP and AP she's a trained person and a clinical instructor at the University of Colorado, and she's also the CEO of Feeding Fundamentals, and I guess we will hear more about that. Thank you.
Yeah. Okay. Hopefully. Look. There are a lot of things going on. Okay, while Stina pulls up my talk, I just wanted to say thank you very much for inviting me. I'm very excited to tell you about some of the work that I've been involved with. It sounds very loud. It's okay. All right. And I also want to just let people know that I think I got invited. Thank you. Yes, because I shared a similar talk at the NIDCAP trainers meeting, and the reaction from everyone from Sweden was horror. And so one of the things that you're going to see, oh, okay, that's just different. That's okay. No, I can do it this way. I think, is that you do have a very different perspective. So I am from the United States, and as I guess to put this into context, many of the families that I work with in the United States, you are guaranteed your job for a 3-month period after you have a baby. But you do not have to be paid anything by your employer. So it is very common for the moms that I work with to deliver a preterm baby, and as soon as they can physically go back to work, they will go back to work, and they will work full-time, coming into the intensive care nursery for some period of time in the evening. That's if they don't have other children. Many of the units don't allow other children in the unit, and so then the parent has to split their time. And so it is a very different perspective, and I absolutely agree with Renee that one of the things that we have to do is to advocate for changes, and we are very far behind you in even some basic social supports for our families. So with that, I'm going to be talking a little bit about where different places are going when they're trying to support feeding in these babies. And I love the fact that the whole theme is on pleasure, because you're going to see that's not one of the measurable outcomes. And Nils, you talked about that. When we start looking at feeding outcomes, people don't look at pleasure as a measurable outcome. We'll talk a little bit about that. I have the pleasure of building on this morning, and one of the things that I was telling Jeffrey is that the very beginning talk was helping us to think about that breastfeeding is a biological expectation for mammals. And so as soon as we step out of breastfeeding and into bottle feeding, which is what many countries are doing, I think we need to really understand that this in and of itself brings in unique challenges. And so we're going to be talking a little bit about both. Yes, I do have a company. I have developed a feeding program, and so you will hear about that as part of this talk. So you just need to know that. But that's not the only thing that I'm trying to achieve in this talk. So first thing is to think about this idea of feeding, and are we all thinking about the same thing? Are we thinking about the food? We had some lovely talks about breast milk and what breast milk brings. We've also thought about breastfeeding. But the words that we use even, sometimes I think get in our way, if you will. And so when we use phrases like feed the child, feeding to me is the experience, and my goal as a therapist is to really support the parent-child during a time of development and the development of feeding and of parenting, as we've heard from Sophia. So let's talk a little bit about what we know about infant feeding outcomes. The research, I'm just giving you some very brief research studies in some cases, and then we'll go a little bit deeper in others. But we know that most preterm babies do learn how to eat, either breast or bottle feeding, and are going home. Now that is the moderately preterm baby, fewer than 1% in a fairly large study of about almost 5,000 babies were discharged fully feeding. The vast majority of babies are able to orally eat, either breast or bottle feeding. However, when you start looking at the extremely preterm born baby or babies who have medical complexities, you see that we do have ways to go, if you will. And I will tell you in the Jad Churla article, again, this is being influenced by our culture and by an inordinate amount of pressure to get babies out of the hospital. And the problem with that is if you don't have a system to support babies after they go home and parents after they go home, then that's, I think, another place where we have some improvements. One of the other things that I think is important for people to really remember is that the World Health Organization definition of exclusive breastfeeding is about human milk and the exclusive provision of human milk, and not necessarily how the baby is fed. And this leads to, at least in the US, a belief that most babies are doing okay. For instance, in my hospital setting, at lunch I was thinking about this and talking with Jillian, your next presenter. I've worked in the intensive care nursery for 28 years. I sat down and I thought, that can't be right. And I kept doing the math and I thought, yep, I have worked in my intensive care nursery for 28 years. I can remember 4 families that went home exclusively breastfeeding if they had a baby that was born under 30 weeks. 4 in 28 years. And all of those families, we were overjoyed that we were able to do that. Those 4 families, the mother quit work and was able to do that and to be in our hospital. And so we think in my hospital, we measure exclusive breast milk provision. We provide donor milk to all mothers, healthy term babies as well as preterm babies while they're in the hospital. And yet we're not really focusing on the act of breastfeeding, which is a foundation of mammals. And so I think that, again, part of what I'm trying to share with you is you are ahead of at least some of us, at least many of us, I guess I would say. And so, like Renee, I do recognize that even with all of these supports, that providing breast milk, supporting mothers, helping mothers to exclusively breastfeed, and this is actually breastfeeding and not just providing milk, is a challenge that even in the best of circumstances, parents need a lot of support to do. When you start looking outside of the intensive care nursery, though, I actually have had the pleasure of working with children who are not eating or not eating well. Basically, almost as long, 25 years. I've been working with 1 foot in the intensive care nursery and 1 foot in a feeding clinic. And some of the other things that we have learned about feeding is when you start looking at the quality of the feedings post breast or bottle feeding, that we're already seeing some differences. This is a lovely study out of, I believe, Denmark, and you see that when you watch a parent and child during the transition to solid feeding with spoon feeding of cereals or pureed foods, feedings are prolonged and messy. Much of the food drops out of the mouth. The pace of the feeding is very rapid. There is an increased sensitivity of the babies to the textures of foods, temperatures, and tastes, and that both the infant and the feeder are impatient, that there is a disconnect between that synchronicity that we like to see during oral feedings. We know that when we look at even the late preterm baby, while we're talking about the ultra preterm baby, I just want to share with you that actually the lack of desire, the disinterest in eating is not unique to the early born. This is a study where, as you can see, they looked at outcomes for extremely early born, up to the preterm 34-week baby, 33 and 6/7 weeks, and then the later born, the late preterm baby. And actually, there was no difference in those two groups when they looked at appetite. Appetite was low across those two different groups. 12 to 14% of babies were identified as just really not having a lot of hunger, and this is up through 12 months adjusted age. At 3 and 6 months, between 2 and 4% of the children had high avoidant behaviors, so they were really trying to escape feeding activities. And maternal anxiety runs medium to high in 25 to almost 40% of parents at the 3 to 6 month age range. But none of these were statistically significantly different in the late preterm and the very early born. Babies who were born early, the under 34 weekers, did have higher rates of dysfunction in oromotor abilities at both 3 and 12 months. You see the borderline at 3 months was 19% versus 13%, and at 12 months was 6% versus 4%. High oromotor dysfunction was much more common in the early born baby. High avoidant behavior was statistically significantly more commonly seen in the early born babies, and maternal feeding anxiety at the 12-month age range was running higher in the early born population. We know that babies who are born preterm continue to struggle with skill acquisition. So it's one thing to learn how to suck and swallow and breathe. It's another to learn to transition to textures and to learn chewing. And today we found out that they're completely separate systems, although I had already had my big surprise moment when I had a conversation with Jeffrey a couple of, actually I guess it was only a couple of months ago. But so we know that there is a correlation, however. And I think one of the things that's really important for us to think about is why, if we have two separately developing systems, why is it that they are influencing each other in the baby? I think it comes back to pleasure, and that things that are fun are much more likely to be acquired. Things that cause pain and discomfort, I think, even though they're different systems of skill, I think we have a commonality there. And long-term outcomes, you see again that preterm babies just are not interested in eating. They also have a smaller repertoire of feeding, of food. We know that parents are expressing struggles. They start using what we call in clinic external rewards for eating. So eating actually rewards us for eating, because we're uncomfortable, we eat, we have pleasure during eating, and we feel better after eating. And yet what we see with parents of preterm babies is that because the baby doesn't eat because eating is fun, parents start to reward eating. So they start to do things like showing the child an iPad and playing movies while they're trying to get the volume into their child, or using other kinds of external reward systems. And you see that about 80% of parents say that eating is the most important factor that they are concerned about. They worry about the volume. They worry about the quality of the diet. And so these are the parents that I work with outside of the hospital. So I guess this first part was just to review that feeding that we're talking about lays a foundation, and this is at least a belief system for me, that if we can support parent-child interaction and the skills of eating right from the very beginning, at least we may have a stronger foundation for parent-child interaction later on, as well as eating skills, because we have focused on pleasure. And so far, that's not been the focus of a lot of research in feeding. And so now let's talk a little bit about what are the interventions that people are trying. I think it's important to remember that all of us are trying to make things better for babies, but it depends on what we're focusing on. And so we're going to talk about motor-based interventions, and we're going to talk about infant-led feedings, and I see them quite differently, and you're going to see how I define those. When it comes to oral stimulation, I do want to point out one thing. There is a Cochrane database review that talks about some improved outcomes with oral stimulation. However, oral stimulation needs to be defined well because what you will see is that oral stimulation currently includes research on taste, research on things like kangaroo, things like sucking, non-nutritive sucking, as well as these kinds of programs. And I think once I describe them, we'll all have an understanding of why we need to look at these very differently. So we're going to first start talking about programs that are more coming from a perspective of motor-based learning, motor learning. And when you look at the outcomes that people are using to determine if there is success in the use of these, decreased length of stay, earlier post-menstrual age at full oral feedings, decreased time to achieve full oral feedings. What is missing? Pleasure. Does it matter? And if we're not looking at it, if we're not measuring it, if we don't even have a proxy for it, then what are we not perhaps understanding about feeding? So when I talk about the oral stimulation programs here in just a minute, I've reviewed, I think it's 15 single studies and 2 meta-analyses that are focused on programs. These are the programs. So these are not programs that are trying to pair taste with tummy getting full. These are programs that range in duration from 5 to 15 minutes. So that's 15 seconds. So when we start thinking about the kinds of things that are being done to babies, think about 5 minutes is a very long time. These programs are done to infants, and I use that word specifically, done to infants as early as 29 weeks. So these are common stimulation techniques. And I want you to think about how you would do this. And I want you to actually try doing it on yourself. And these are repeated over and over again across the studies that we're going to look at. So I see a lot of you trying to do the right and left cheek compression from the ear to the corner of the mouth. Now, when you think about biological expectations, hey, upper lip compression from the middle of the nose, the base of the nose to the middle of the lip. Hey, lower lip compression. That's on the outside of the mouth. What about the inside of the mouth? Taking your finger, putting it on the front of your tongue, pressing down. Going back, pressing down, going back, pressing down, going back, pressing down. At what point do we gag? How about compressing the hard palate? So pushing up on the hard palate. So the reason why I share these things with you is because from a motor learning, what people are saying is, well, when a baby is sucking, their mouth is going up and down. There's touch on the inside of their mouth. There is potentially touch on the outside of their mouth. And so we need to stimulate those things. But what I so appreciate about this morning is thinking about the biological expectations that inside in the womb, we wouldn't be doing these kinds of things. And yet somehow we've decided that instead of focusing the attention on bringing parents and babies together, we are thinking motor-based learning and thinking about stimulating. So that's why I said it's important to, when you hear the words oral stimulation, ask that deeper question. What kind of stimulation? Non-nutritive sucking, taste, smell, kangaroo mother care, those are stimulation that is biologically expected. So these are the studies that I have listed out. You will have the references at the end of this talk. You see that there are 2 meta-analyses. Now, both of these meta-analyses, one has 8 studies, one has 11 studies, and both of them have included non-significant findings, and both of them have said there's so much heterogeneity across these studies that really it's impossible to look at them together, and yet we do. And so I think that's the other piece that I really want to bring here, is that this may not be part of what's happening in these Nordic countries or in Europe, but I can tell you it is something that's happening and growing. And so when you look at length of stay, there are 2 studies that show a decrease in length of stay that is associated with the babies who had oral stimulation. However, neither of these studies show a decrease in the age at which full oral feedings were achieved. So there are lots of factors that affect length of stay. Feeding is only one of them. You see the vast majority, it's not significantly improved, but no one talks about those. And some of them didn't assess length of stay. Postmenstrual age, when you acquire full oral feedings, is significantly improved in 3 studies, but not in the other studies, and again, not assessed in 4 of the studies. I do want to point out, oh, all right. Postmenstrual age at full oral feedings. What you see in this is that actually there are a couple of studies where you have an increase and you have no increase in things like length of stay or in postmenstrual age. And that's when there are different babies, different groups, different cohorts. And so sometimes the results are mixed. And so for instance, there is one study there that was done by Stephen Barlow that you will get more information on, where in one instance it improved, or it decreased, I should say. It was associated with a decrease in length of stay, and in another group, in the same study, it was associated with an increased length of stay. Days to reach full oral feedings is where you see the most significant improvement, but I want to point out that that is the number of days from the start of oral feedings to achieving full oral feedings. And in the vast majority of those studies, the time point of starting oral feedings was not consistent. And so when you have a shorter duration, it is equally plausible that the babies who receive oral stimulation are not able to start oral feedings until later. And so that kind of data is really tricky to find. So these are the things that I look for when I'm reading the articles on oral stimulation. There are a number of methodology concerns that I bring up, in my opinion, that we need to be thinking about. One is that I actually gave you the oral stimulation motor movements that are associated with oral feeding in babies. But some of the programs are using 15-minute program where it includes grabbing the tongue and moving it side to side, which is not even a movement pattern that is used in infant feeding. Oral stimulation studies often use what's called a sham intervention that is no contact. So these babies were not even picked up, did not get a pacifier, did not get any intervention, any touch at all. And so when you think about being picked up and not being picked up, the influence of human contact we know is a factor. There's no post-discharge outcomes in these studies. No one's looking after they go home at what happens to these babies after go home. There's no study that has involved parents. research studies that I'm talking about right here. And so we've already heard about how important it is to bring parents and to help parents be parents. Only one study has addressed medically complex infants. The vast majority of them are trying to speed up what I consider to be a normal acquisition of feeding. In 5 publications, 5 out of 15, 5 publications, the intervention was either stopped due to or they noted a statistically significant increase in bradycardic episodes after interventions. And in several publications, there's no information on stability. So when we think about pleasure and we think about the feedback systems that we've been talking about, thinking about how do you measure pleasure? And we were having a conversation last night, and Nils said, well, pleasure and physiology, I mean, that's a place to start. So I would say if I'm doing something to a baby and they drop their heart rate into bradycardia and they desaturate and I have to stop to get them back, that can't be pleasant. And yet people don't even acknowledge that's a problem. They just make a note that this happened. 9 out of 10 babies in one study. And poor weight gain has also been identified, and yet that's not an outcome that most people are addressing, and so they don't do statistics. You have to be able to look at the weight at start and the weight afterwards. So that's a different perspective on oral stimulation, because it's really not the biologically expected kinds of interventions that we've been talking about. Let's talk about the N-Trainer. The N-Trainer is a program, it's a machine, looks like a pacifier with a stick on it, and it pulsates inside the mouth. And so you put it in the mouth of the baby, you turn it on, and it will move the mouth of the baby. And the idea is that it will entrain the motor patterns for movement, for sucking. Okay, again, no thought to pleasure when we start thinking about this. And so when you look at the data that supports this, first of all, none of the studies have shown a more rapid transition to full oral feedings. This study did show that they had increased the percent of volume that the baby was eating. However, my question is always, why would you stop at a time point before reaching full oral feedings? And so those are the kinds of questions that I ask of these people. Song's study in 2014 is listed as a reference for the statements about improved oral feedings, and yet there was no oral feeding outcomes in that study. And then this is a study where Dr. Barlow, who I've had great conversations with, they used the pulsating pacifier, the N-Trainer, and what they found was chronic lung disease infants given the pulsed pacifier treatment stayed in the NICU for a significantly shorter period of time compared to babies with chronic lung disease, on average 2.5 days less. However, you see that there's also information in the same study that children who had respiratory distress syndrome receiving the pulse pacifier treatment remained in the NICU 4.3 days longer. And yet no one talks about that half of the equation. And you see in the chart here that differences seen in the healthy preterm cohort were not statistically significant. So I really come back because of my NIDCAP training, come back to this idea that we want to think about feeding not just from a motor pathway, but really from a learning pathway. And what are some of the dangers to creating instability? And how do these interventions influence normal development? Are we interfering with normal development? Dr. Gaudet, who is a gastroenterologist, made a comment at a conference once that feeding problems are the unintended consequences of medically necessary interventions. And so it begs the question, what are the unintended consequences for some of these programs. So we're going to take a little bit of an aside, and we're going to think long term, and we're going to ask ourselves what helps babies learn about eating? Well, there's strong evidence that much of learning to eat is actually driven by maturation. We also know that if you have medical complications, that can delay the acquisition of oral feedings. So what does that leave? That leaves experiences. That leaves what are the things that we can help that also influence baby and infant development. So I come at everything from a dynamic systems theory. I'm not going to, because of time, go into a whole lot of detail around how dynamic systems theories work. But certainly one of the things that we know is that babies are continuously interacting, and they're giving us information about what is working and what is not working for them. And so the Synactive Organization of Behavioral Development, which underlies NIDCAP, is a model that certainly I use and I use for teaching as well. And as we've already talked a little bit about, babies communicate through autonomic signals, motor signals, behavioral state. Watching their behavioral state is really important, and then looking at their ability to attend and interact. And out of the organization of these systems, babies then can start to interact with each other. As the systems organize, the baby reaches levels of homeostasis. That homeostasis then allows them to take on new challenges. And sometimes the challenges are internal challenges like feeding or feeding tolerance, and sometimes those are external challenges like eating itself. So there's that piece, and then there's the experience piece. And this is one of the favorite quotes I've ever found. Practice is everything. It's often misquoted as practice makes perfect. And so what we need to think about is how do we support pleasurable experiences that then can progress into better outcomes. So when in my facilities, we talk about quality leads to quantity, not either or, but the practice that's positive, that is supporting parents being the primary feeders, that is supporting babies feeling like their experiences with feeding are really pleasurable. Those lead to acquisition of full oral feedings. So when you start asking, well, why do babies stop eating? I think what we need to think about is that they are trying to do what's best for them. And so in the theory of neuronal group selection, they acknowledge the motor learning that we've just talked about, that the more you do something, the more you build brain pathways for those motor patterns. However, they also point out that eating is a complex motor activity, and that we're actually creating global neural maps, and through repetition, the infant selects the patterns that most successfully support their developmental strivings. So when we have children who are not eating well, we have to ask ourselves what's getting in the way of them eating. And certainly I agree, we certainly have babies where the GI system has not been addressed well, and so they have constipation or reflux. Over 50% of children in one research study, children of long-term feeding problems, had reflux as a part of their history. So we certainly can see that. But we also need to think about anything that doesn't feel good can get in the way. And babies will choose to not eat when not eating is preferred to eating. So anytime we have a baby who's not eating well, we have to ask, what is it that's getting in the way of that? Because all experiences are matter. So that's going to lead us to just thinking about feeding from an infant-led program perspective. And there are a number of them. But what we're trying to do, those of us who are trying to support that, this type of a perspective, is to add on to the previously talked about outcomes, and really start thinking about parental competence and infant eating skill, because hunger is one piece of the equation. But even if you are hungry, even if you recognize hunger, if you don't have the skill to achieve the intake, then we still haven't met our goal. So infant eating skill, enjoyable experiences, and then fewer readmissions, I would say, is another goal for us. So as we start shifting over, just to recognize that the emergence of the feeding system, separate from the suckle system, happens in most babies, I would say, between 2 and 4 months of age, where while they continue to breast or bottle feed, they're moving into more voluntary feeding patterns. And so that actually is a time period where sometimes babies who were eating start to really struggle. And so we want to kind of think about looking long term. So infant-led feeding interventions are designed to follow the infant's lead. Hopefully, the ones at least that I'm talking about focus on stability, focus on parental involvement, focus on pleasurable experiences, and continue to look at the age at which babies reach full oral feedings and length of stay, because those are being driven by outside sources. Those confines are. But we're really trying to build a strong foundation for long-term feeding success. So these are just some that I've pulled out, and Jillian is going to be talking about some of the specific interventions and the data behind some other specific interventions, but these are more kind of global. So ones that are looking at some sort of self-scheduling, co-regulatory approach, I want to share with you that Suzanne Thorey has created, other parent involvement approaches, the SOFI method, which is the one that I've created, and then we'll end on breastfeeding, because breastfeeding, it's really hard to make a baby breastfeed. So it's the ultimate infant-led program, as far as I can tell. So self-scheduling. Only one study actually has gone to what you would want, which is completely taking the schedule away and letting babies tell us what they would like to do in the hospital when it comes to bottle feeding. So self-scheduling, there's one that does that, and then there are two others that two other studies where they have said, if the baby arouses at care time, at scheduled care time, then we should orally feed them. We should offer a feeding, and if they take 5 mLs or they take 30 mLs, whenever they say that they're done, if they get tired or they become unstable at all, then we would stop and gavage. Similar to the other oral stimulation programs, there's no increase or decrease in length of stay, but there is a decrease in adverse events in apneic and bradycardic episodes in 2 of the studies, and a decreased time to reach full oral feedings in 2 of the studies as well. The co-regulatory approach. So the co-regulatory approach is really just designed to help the feeders, and this first study was the bedside nurse, designed to help the bedside nurse really assess what's going on during a feeding, looking at behavioral, auditory, and physiologic feedback, and then provide some specific interventions to improve the feedings and the pleasure of feedings, if you will. Suzanne then took that approach that she could show helped caregivers be more responsive, and the nurses that were trained in the co-regulatory approach then turned around and worked with families. Now, one of the nice things that came out of this study was really they were studying the parents, not the baby, and they asked the parents, what is it that they need help with? What is it that nurses can really help parents with to improve the feeding and to reach that attuned feeding? And so the parents said, I need validation of my understanding of what my baby is telling me, and how do I help them breathe and eat? Bottles are very different than breastfeeding. These were all bottle-fed babies. How do I provide stability for their body during feeding? How do I regulate milk flow? And when do I provide some supports around that. So the study was a qualitative study, not a quantitative study. Parental involvement programs. I'm not going to talk about kangaroo mother care here because we have Jill coming up, and I thought, well, I would never be able to do it justice. But I can tell you, every time I go to a conference and I hear about the benefits in term babies, in preterm babies, for parents, for mothers, for fathers, for breast milk, clearly kangaroo mother care approaches improve outcomes across the board. There is a study that came out that was an observational study, and what they found is that the earlier parents fed their infants and the earlier that kangaroo mother care was started, the lower the postmenstrual age at achieving full oral feedings. I'm not sure that I would be looking at achieving full oral feedings as an outcome because A, it's very biologically driven, and B, I think it focuses us on the wrong thing. But historically, that's certainly been the case that we're looking at that. So I want to just share with you a little bit about the SOFI model because there are 2 studies now that have looked at outcomes using it. So the idea behind the SOFI method, SOFI stands for Supporting Oral Feeding in Fragile Infants, is that we start with doing everything we can to improve baseline homeostasis. So it implements early kangaroo mother care. It implements getting parents to be the active participants as early as possible, and out of baseline stability, we recognize that anytime we try a feeding, whether breast or bottle feeding, that there is a challenge that we are providing basically, and then we move to, depending on what the baby is telling us, we can implement some supports to decrease the challenge and increase the pleasure, if you will. The program itself is really centered around an algorithm. The algorithm is designed to help caregivers know what to look for, what kinds of decisions should we be thinking about, or what kinds of decision points should we be thinking about. Things like, is this baby stable? Which you might think would be a silly question, but is actually a big question when it comes to oral feeding. And then, based on the baby behaviors, we should have similar interventions based on the baby behaviors. And so I can make this available for people. So the first study that came out using this was really a pre-post intervention of the SOFI method by staff at a hospital that has about 600 admissions a year. It's a children's hospital, and so they implemented it across the board in the preterm population as well as the term population. You see that they used an MI score to look at severity of illness because they really accepted all babies. It wasn't just healthy preterm babies that they were looking at. And about 2/3 of the babies actually were quite ill. You see that preterm and term, they were a little bit more term babies than preterm babies. And then what was really unique, I think, is that they called the parents after they went home. So in this time frame when babies start to take on voluntary eating, we felt was a really critical time frame. And so they wanted to look and see if babies whose parents had been really supported to think about pleasure as an important concept, whether those babies were doing better after going home. So much like other research studies out there, really didn't find many differences in hospital. With the preterm babies, the days to full PO feedings was shorter. Again, I'm not sure the relevance of that. Where the differences started to show up was after going home. And the idea behind this was that if the staff were making decisions based on shared cues and responses, they were then teaching parents to do the same thing, who then were able to go home and continue working with their babies after going home. So there wasn't an increase or decrease in length of stay, but there was a decrease in some of these behaviors that we see post-discharge. There is one additional study that has come out of this. They pulled out the babies who had an NMI of 4, and they looked at outcomes for those babies. And a similar percent of those babies went home with NG tube feedings, so they were partially orally fed, partially NG tube fed. But at that 3 to 5 month time frame, a statistically significant larger number of those babies had transitioned fully onto full oral feedings post-discharge. Now, there was another study, again, these are very small, very simple studies that are more clinical based, and so these are not the pristine, very well controlled studies. In this study, again, they basically did a retrospective. These were babies with bronchopulmonary dysplasia that were on nasal CPAP, and so they took this idea that we can use infant behaviors and stability as a marker for pleasure and offer feedings and stop if the baby says, oh, this is too much for me. And you see how they accomplished that. So they were able to reach full oral feedings much sooner, although, again, the caveat to that is that these babies were allowed to try feeding on nasal CPAP compared to babies who weren't being offered that option. Length of stay wasn't different. Readmission was not statistically significant either. So I want to wrap up by talking about, obviously, breastfeeding. As I mentioned, it is still an uphill battle. I was sharing that I have a neonatologist, in fact, the director of my unit, who tells families on a regular basis, oh, we want to support you. We want to, help you to breastfeed your baby. If you wanted to try and be exclusively breastfeeding, we can do that, but it will mean you will be here a lot longer. And I keep coming back to him and saying, that's a myth. And I've shared with you the research that shows it's a myth. And that's your belief system. And you need to stop telling families that, because I come along and then I'm backtracking and saying, if you want to breastfeed, actually babies breastfeed better than bottle feed. They get into less problems breastfeeding than bottle feeding if you start looking at physiologic parameters and not just volume. And so beautiful review study in 2015 really talks about these myths and it just brings us back to, if we could help parents breastfeed, we are achieving pleasurable feedings, and we are achieving parental confidence and competence, enjoyment, and it doesn't mean that they are going to be in the hospital longer, clearly. Babies don't spend more energy. There are a lot of caveats to that. So I guess the take-home points for this section is that feeding abilities are influenced by medical comorbidities and maturation, which are not in our control in some cases, and experiences. And experiences are modifiable through staff and parental interactions during feedings. So feeding interventions that are infant-led focus on enjoyment, improved quality of feedings, parental confidence and competence, which in turn may lead to enjoyment and improvement of long-term feeding outcomes. Without a consistent focus on pleasurable feeding experiences and parental involvement, parents may lack an understanding of why feeding is challenging. Parents get a lot of conflicting messages around feeding, specifically with bottle feeding, and they may lack the ability to help their child overcome some of these skill or experience-based rejections. But when parents are primary feeders and improved enjoyment during feeding experiences are our goal, we may be able to help improve long-term feeding outcomes. And so that's my kind of take home, I guess. And I'm going to leave you with the first set of twins that went home exclusively breastfeeding out of my hospital. So thank you.